These are the viewing guidelines. Give utmost focus and attention to the video. This video will be used to answer the small group activities in the classroom. The pre-test and the post-test will close on August 25, 2017 at exactly 1 p.m. The video will be posted again after the small group activities. Welcome to Pediatric Gastroenterology and Hepatology Pathologic Division. I am Dr. Kasubha. The objectives of this session is to diagnose children with different gastrointestinal and hepatic problems and manage children with different gastrointestinal and hepatic problems. In this session, we will discuss Hirschsprung's disease, Meckel's diverticulum, acute gastroenteritis, viral hepatitis, biliary atresia, and intestinal parasitism. Hirschsprung disease is a congenital aganglionic megacolon. It is neurocrestopathy of the enteric nervous system characterized by absence of ganglion cells in the submucosal and myenteric plexus. It is the most common cause of lower intestinal obstruction in neonates, with an incidence of 1 is to 5,000 live births. It may be associated with other congenital defects. Hirschsprung disease is a result of an absence of ganglion cells in the bowel wall, extending proximally and continuously from the anus for a variable distance. It is a consequence of an arrest of neuroblast migration from the proximal to the distal bowel. So, without the myenteric and the submucosal plexus, there will be inadequate relaxation of the bowel wall and bowel wall hypertonicity, which in turn cause intestinal obstruction. It is usually limited to the rectosigmoid area at about 80%, and 10 to 15% have long segment diseases. Rarely, there is total aganglionosis. Hirschsprung disease usually is diagnosed in the neonatal period, presenting with distended abdomen, bilus emesis or aspirates with feeding intolerance, unable to pass meconium, or some may pass meconium normally but subsequently present with chronic constipation. Meconium passage should be observed in the first 48 hours of life. Here is an abdominal X-ray of a child with Hirschsprung disease. Failure to pass stools lead to dilatation of the proximal bowel and abdominal distension. As the bowel dilates, intraluminal pressure increases, resulting to decreased blood flow and deterioration of the mucosal barrier. Stasis allows bacterial proliferation, which can lead to enterocolitis by Clostridium difficile, Staph aureus, anaerobes, and coliforms. Hirschsprung disease in older patients must be distinguished from other causes of abdominal distension and chronic constipation. In the symptomatology, for functional constipation, the onset is usually after 2 years of age, whereas for Hirschsprung disease, it is usually at birth. Encompresses is common in functional constipation, but very rare in Hirschsprung disease. There is failure to thrive or possible failure to thrive for Hirschsprung disease and uncommon for functional constipation. There can be possible enterocolitis for Hirschsprung disease. And Forced bowel training is usual for functional constipation. For the physical exam, abdominal distension is common for Hirschsprung disease, as well as poor weight gain. The rectum is empty in Hirschsprung disease. Upon rectal examination, there can be explosive passage of stool after direct rectal exam. Malnutrition may be possible for Hirschsprung disease. For diagnostic modalities, anorectal manometry measures the pressure of the internal anal sphincter while a balloon is distended in the rectum. In normal patients, rectal distension initiates relaxation of the internal anal sphincter, while for Hirschsprung disease, there is failure to relax. In rectal biopsy, there is no ganglion cells or increased acetylcholinesterase staining in Hirschsprung disease. For enema or barium enema is most likely to aid for children older than 1 month because the proximal ganglionic segment might not be significantly dilated in the first few weeks of life. Usually, in Hirschsprung disease, there is a transition zone with delayed evacuation for more than 24 hours. This is a fluoroscopy of Hirschsprung disease. Note that there is megacolon noted in the rectosigmoid area. Classic findings are abrupt, narrow transition zone between the normal dilated proximal colon and a smaller caliber obstructed distal ganglionic segment, as depicted with the arrows. In neonates, it must be differentiated from meconium plug syndrome, meconium ileus, and intestinal atresia. The definitive treatment is operative. The next topic is Meckel's diverticulum. It is the remnant of the embryonic sac from the omphallomesenteric duct or the vitelline duct. It is the most common congenital gastrointestinal anomaly, and it is an outpouching of the ileum along the antimesenteric border 50 to 75 centimeters from the ileocecal valve. Here is the picture of Meckel's diverticulum. Meckel's diverticulum usually arise in the first or second year of life. Initial symptoms can occur in the first decade of life, with intermittent, painless rectal bleeding by ulceration of the adjacent normal ileal mucosa. When inflamed, called diverticulitis, can manifest similarly to acute appendicitis, with a mean age of 8 years. The ectopic mucosa causes the painless rectal bleeding, usually of gastric origin, but it can be pancreatic, jejunal, or a combination of these tissues. Stools can be brick-colored or currant jelly-colored. It may also present with melanotic stools, which are less dramatic bleeding of Meckel's diverticulum. Bleeding can cause anemia but self-limited because there will be contraction of the splanchnic vessels during hypovolemia. Meckel's diverticulum may cause obstruction and acts as a lead point in intussusception, or intraperitoneal bands connecting residual omphallomesenteric duct remnants to the ileum and umbilicus. In turn, there is internal herniation or volvulus of the small bowel around the band. Diagnosis depends on clinical presentation. Plain abdominal radiographs have no value for this disease. Barium studies rarely reveal the diverticulum. Meckel radionuclide scan is the most sensitive study for this disease, wherein there is IV infusion of the technetium 99M per technetate for this disease. Here's the picture of the scan. The mucus-secreting cells of the ectopic gastric mucosa take up the pertechnetate, permitting the visualization of the Meckel's diverticulum. Radio-labeled tagged RBC scan, the patient must be actively bleeding to do this diagnostic modality. However, you can also do abdominal ultrasound, superior mesenteric angiography, abdominal CT scan, and exploratory laparoscopy. Treatment is surgical excision. Acute gastroenteritis is one of the most common disease entities that you will encounter in pediatrics. It is infection of the gastrointestinal tract. It can be caused by viral, bacterial, parasitic pathogens. It can be foodborne or waterborne and usually presents with diarrhea and vomiting. There can also be abdominal pain and fever, and there is usually fecal oral route transmission of the disease. For the definition of terms, diarrhea is best described as excessive loss of fluid and electrolytes in the stool, and passage of unusually loose watery stool at least 3 times in 24 hours. The normal value is 5 ml per kilogram per day for infants and 200 grams of feces in 24 hours for adults. The clinical types are there are four clinical types of acute gastroenteritis. Acute watery diarrhea, including cholera, acute bloody diarrhea or dysentery, persistent diarrhea, and diarrhea with severe malnutrition. Acute watery diarrhea lasts for several hours to days. The main danger is dehydration. For dysentery, the main dangers are damage of intestinal mucosa, sepsis, and malnutrition. Persistent diarrhea lasts for 14 days or longer, and the main danger is malnutrition and serious non-intestinal infection. Diarrhea with severe malnutrition, the main damage are severe systemic infection, dehydration, heart failure, vitamin and mineral deficiencies. It usually accounts to 18% of childhood deaths and 1.5 million deaths per year globally and is the second most common child deaths worldwide, second to pneumonia. 2.5 billion episodes per year in less than 5 years old in developing countries. The global mortality may be declining, but the overall incidence of diarrhea remains unchanged at about 3.6 episodes per child year. There are different etiologies of acute gastroenteritis. We will discuss some of them. Rotavirus, which accounts to 15 to 25% in children in 6 to 24 months of age, and is the most common cause of watery diarrhea, with an incubation period of 1 to 3 days and a duration of 4 to 8 days. There can be patchy damage to the epithelium of the small intestine, blunting of the villi, reduction of activity of lactase and disaccharidase. Symptoms are vomiting, watery diarrhea, low-grade fever, temporary lactose intolerance. Shigella, on the other hand, accounts to 10 to 15% of acute diarrhea and is the most common cause of bloody diarrhea in children, with an incubation of 24 to 48 hours and 4 to 7 days duration. Shigella invades and multiplies within the colonic epithelial cells, causing cell death and mucosal ulcers. Smooth lipopolysaccharide cell wall antigens which also secrete the Shiga toxin. There can be abdominal cramps, fever, diarrhea. Stools might be contain blood and mucus. E. coli accounts to one-fourth of all diarrhea in developing countries. The enterotoxigenic E. coli causes secretion of fluids and electrolytes resulting in watery diarrhea. ETEC does not destroy the brush border or invade the mucosa, and it is self-limited, but it's the most common cause of diarrhea in travelers from developed to developing countries. Please read through this slide. These are also the different types of E. coli causing diarrhea. You can freeze this frame for you to read them. EHEC, or the enterohemorrhagic E. coli, is found in Europe and in parts of North and South America. Outbreaks may be caused by undercooked meat. It has an incubation period of 1 to 8 days and a duration of 5 to 10 days. It also produces a Shiga-like toxin that may be responsible for edema and diffuse bleeding in the colon. Signs and symptoms are severe diarrhea that is often bloody, with abdominal pain and vomiting. Campylobacter jejuni is spread by chicken and other animals, raw and undercooked poultry. Vibrio cholera is endemic in many countries of Africa, Asia, and Latin America. It is usually during the hot and wet season with a peak incidence of 2 to 9 years old. It has an incubation period of 24 to 72 hours and a duration of 3 to 7 days. The Vibrio cholera adhere to and multiply on the mucosa of the small intestine where they produce an enterotoxin. And symptoms are profuse watery diarrhea and vomiting, which can lead to severe dehydration and death within hours. One bout of diarrhea can cause severe dehydration for patients with Vibrio cholera infection. Salmonella, on the other hand, may occur and can lead to localized infection in other tissues, such as bone and meninges. Symptoms are diarrhea, fever, abdominal cramps, and vomiting. Giardia species can be seen worldwide, with a peak incidence of 1 to 5 years old. These are foodborne and waterborne diseases. It has an incubation period of 1 to 2 weeks and duration of days to weeks. It infects the small bowels and pathogenic mechanism is still unclear. It can cause acute and persistent diarrhea, sometimes malabsorption, weight loss with fatty stools, and abdominal pain and bloating. Entamoeba histolytica, on the other hand, is also seen worldwide. Incidence increases with age and waterborne, with an incubation period of 2 to 3 days to 1 to 4 weeks and may be protracted to several weeks to several months. It invades the mucosa of the large intestines. It is thought to elaborate neurohormonal substances that can cause intestinal secretion and damage. 90% are asymptomatic if there is the cyst form. It is range from persistent mild diarrhea to fulminant dysentery to liver abscess for trophozoid infections and tenesmus. Amoeba sometimes can be foodborne if infected by food handler. Cryptosporidium food may also be contaminated by ill food handlers. Symptoms are acute watery diarrhea, persistent diarrhea in severely malnourished and immunosuppressed children, for example, in AIDS patients. What are the major risk factors for acute gastroenteritis? It can be environmental contamination, increased exposure to enteropathogens, and additional risk factors are age and immunodeficiency, as well as measles infection and malnutrition. Lack of exclusive or predominant breastfeeding can also be an additional risk factor for AGE. Assessment of a child with diarrhea using the history. Usually there is presence of blood in the stool. You ask for the duration of diarrhea, the number of water stools per day, the number of episodes of vomiting, and the presence of fever, cough, or other reported problems like convulsions or recent measles infection. For the physical examination, you need to first assess the hydration status of your child. If there is minimal or no dehydration, mild to moderate dehydration, and severe dehydration, as depicted in this table. Please read through this table. These are the parts of the physical examination you need to know for the different degree of dehydration present in the child. You can freeze this frame for you to read them. According to WHO standards, assessment of diarrhea patients for dehydration look at condition, the eyes, thirst, feel for the skin pinch, decide on what level of hydration or dehydration the patient has, and then treat accordingly. For treatment plan A, the child is well, alert, and normal and drinks normally. The skin pinch goes back quickly, and then decide if the patient has no signs of dehydration. Then treat using treatment plan A. For B, the child is restless, irritable, sunken eyeballs, the child is thirsty and drinks eagerly. The skin pinch goes back slowly. If the patient has two or more signs in column B, decide that this patient has some dehydration. Then weigh the patient if possible and use treatment plan B. We will go to the treatment plan later. For C, the patient is lethargic, unconscious, with sunken eyeballs and drinks poorly or none at all. The skin pinch goes back very slowly. If the patient has two or more signs in letter C, decide that this patient has severe dehydration. Weigh the patient and use treatment plan C urgently. The objectives of treatment for AGE is to prevent dehydration, to treat dehydration, and to prevent nutritional damage, as well as reduce the duration of severity of diarrhea and the occurrence of future episodes by giving supplemental zinc. For treatment plan A, home therapy to prevent dehydration and malnutrition, rule number one is to give the child more fluids than usual to prevent dehydration. Suitable fluids are oral rehydration salt solutions, salted drinks, vegetable or chicken soup with salt. Unsuitable fluids are commercial carbonated beverages, commercial fruit juices, sweetened tea, coffee, and medicinal teas or infusion. How much fluid to give to the child? As a general rule, for children less than 2 years old, give 50 to 100 ml of ORS, or 1/4 to a half large cup. For children 2 to 10 years old, 100 to 200 ml or half to 1 large cup. For older children, as much as they want. Rule number 2, give supplemental zinc at 10 to 20 milligrams every day for 10 to 14 days. Zinc is for replacement of zinc lost. It should be given immediately. And it lessens risk of having new episodes of diarrhea in the following 2 to 3 months. Rule number 3, continue to feed the child to prevent malnutrition. So continue breastfeeding, but if not breastfed, continue the usual milk formula or continuously give food. Rule number 4, take the child to a health worker if there are signs of dehydration or other problems, or if there is passage of watery stools, has repeated vomiting, is eating or drinking poorly, develops a fever, has blood in the stool, or the child does not get better in 3 days. For treatment plan B, use ORS reduced osmolarity with sodium content at 75 millimoles per liter, chloride at 65 millimoles per liter, anhydrous glucose at 75 millimoles per liter, potassium at 20 millimoles per liter, and citrate at 10 millimoles per liter. That has a total osmolarity of 245 millimoles per liter. It used to be 90 millimoles of sodium and glucose until it was further revised. How much ORS solution is needed? Here is the table for your guide. Kindly read through them. If you cannot memorize the table, the shortcut is the child's weight in kilograms times 75 ml in 4 hours. Then give zinc, give the usual food or milk in order to prevent malnutrition. For treatment plan C, here are the guidelines for treatment plan C for patients with severe dehydration. Here are the guidelines for intravenous treatment of children and adults with severe dehydration. Kindly breeze through this slide. Use of Ringer's lactate solution is recommended, but if lactated Ringer is not available, you can use normal saline solution. Then, monitor progress of IV rehydration, 15 to 30 minutes until a strong radial pulse is present, or at least every hour to confirm that the hydration is improving. If, if intravenous therapy is not available, you can insert a nasogastric tube. Upon insertion of the nasogastric tube, give ORS at a rate of 20 ml per kilo per hour for 6 hours. If the facility is within 30 minutes, Bring the child to the facility, but if not, still insert an NGT. If there's no improvement for 3 hours after nasogastric tube hydration, bring to the nearest facility. For the management of acute bloody diarrhea or dysentery, the child presents with loose stools or bloody stools. If the child is severely malnourished, refer the child or bring to the hospital. If not, give antimicrobial for Shigella. And if the child gets better in 2 days, complete the 3 days treatment. If not, and initially dehydrated with age less than 1 year old or misses in the past 6 months, bring the child to the hospital or admit the patient. If not, change to second antimicrobial for Shigella. If the child improves, complete the treatment. If not, bring to the nearest hospital and treat for amoebiasis. This table shows you how to treat acute gastroenteritis for the different etiologies of it. Kindly breeze through this slide. Kindly read this table as well. For persistent diarrhea, for the management of persistent diarrhea, it is diarrhea that begins acutely and lasts at least 14 days. Admit patients with systemic infections, dehydration, and infants below 4 months. Treat dehydration, identify and treat specific infections, give a nutritious diet, and supplement vitamins and minerals. Minerals lost during persistent diarrhea are folate, zinc, vitamin A, copper, and magnesium. And then monitor response to treatment. Now we go to viral hepatitis. Below are the features of the hepatotropic viruses for your reading. Clinical manifestations. Clinical manifestations common to all forms are clinical icterus, hepatomegaly, altered sensorium, probably encephalopathy. Differential diagnosis for newborn period can be infection, such as bacterial E. coli, listeria, and syphilis, or non-hepatotropic viruses like HSV, enteroviruses, and CMV. For the metabolic and anatomic causes, it can be caused by tyrosinemia, biliary atresia, genetic forms of intrahepatic cholestasis, and choledochal cyst. For childhood, extrahepatic obstruction can be caused by also gallstones, primary sclerosing cholangitis, pancreatic pathologies, inflammatory conditions like autoimmune hepatitis, JRA, Kawasaki disease, and immune dysregulation, infiltrative disorders like malignancies, metabolic disorders like Wilson's disease and cystic fibrosis, infections like EBV, varicella, malaria, and leptospirosis, as well as syphilis, can also be considered. For the pathogenesis, there is direct cytopathic and immune-mediated injury, and the entire liver is involved. There's also a mix of acute inflammatory infiltrates with bile duct proliferation, and the liver morphology returns to normal after an acute infection, but there's progressive scarring if the illness is chronic. There can be elevation of alanine aminotransferase or aspartate aminotransferase as well as alkaline phosphatase. There can be elevated serum conjugated bilirubin, elevation of serum alkaline phosphatase as mentioned earlier, and prolonged prothrombin time and low serum albumin. For hepatitis A, it is the most prevalent of the five forms of hepatitis. It is responsible for most forms of acute and benign hepatitis, and it is caused by the picornavirus, an RNA virus. It is most prevalent in developing countries and is highly contagious with a fecal oral route transmission, and it is usually foodborne and waterborne. Manifestations are anecteric illness at the start and then acute febrile illness with an abrupt onset of anorexia, nausea, malaise, vomiting, and jaundice. Usual duration is 7 to 14 days. You can request for anti-HAV IgM. It is detectable when symptoms are apparent and remains positive for 4 to 6 months. Anti-HAV IgG, on the other hand, is usually detected within 8 weeks of signs and symptoms. Here is the graph that can show you elevation of the ALT, anti-HAV, and IgM anti-HAV. Hepatitis A in stools is present in the first days of illness. Symptoms present in the first week of illness as well as jaundice. There is no specific treatment for hepatitis A, but supportive treatment is very much warranted. Hepatitis A is contagious for 2 weeks before and approximately 7 days after the onset of jaundice. Hand washing is still the most important way to prevent hepatitis A infection, and pre-exposure immunoglobulins can be given as well as hepatitis A vaccines can be given. Prognosis is excellent and there is no long-term sequelae. Now we go to hepatitis B. It is caused by Hepadnaviridae with the different markers. Hepatitis B infection occur worldwide with high concentration in blood, serum, and serous exudates, with moderate concentration in saliva, vaginal fluid, and semen. Transmission is through blood exposure and sexual contact or perinatal. Acute cases are asymptomatic, but with symptoms, there can be fatigue, anorexia, malaise which occurs 6 to 7 weeks after exposure. Jaundice usually begins approximately 8 weeks after exposure and lasts for approximately 4 weeks. Chronic cases can cause chronic hepatitis, liver cirrhosis, and can cause hepatocellular carcinoma. Diagnosis is made by different markers. The HBsA antigen is first to elevate, and the rise closely coincides with the onset of symptoms. Persistence beyond 6 months defines the chronic infection state. Anti-HBC IgM, on the other hand, rises early after the infection and remains positive for many months before being replaced by anti-HBC and Ig immunoglobulin, which then persists for years. Anti-HBs is positive for children with hepatitis B immunization, and anti-HBs and anti-HBC are detected in persons with resolved infection. HBe antigen is present in active and chronic infection, and anti-HBe marks improvement and is a goal of therapy in chronically infected patients. Here is the graph showing rise in liver markers, which coincides with rise in hepatitis B markers, as well as the symptoms. Treatment of hepatitis B is largely supportive, and the goal is to reduce viral replication with the use of interferon alpha 2b. Lamivudine can be given for children more than 2 years of age, and adefovir can be given to children more than 12 years of age. Prevention can be done by giving vaccines and hepatitis B immunoglobulin if there is a maternal infection. The goal is to reduce viral replication as well. Complications are cirrhosis, end-stage liver disease complications, and primary hepatocellular carcinoma. Hepatitis C is a single-stranded RNA virus from the family Flaviviridae. It is the most common cause of chronic liver diseases in adults. Acute hepatitis C infection is mild and insidious, while chronic hepatitis C infection, it is clinically silent until a complication develops. Anti-HCV is not a protective antibody and does not confer immunity. HCV PCR can also be done to diagnose hepatitis C. Here's the graph that coincides with the elevation of the liver enzymes as well as the hepatic markers with the symptoms. Treatment is peg interferon given subcutaneously weekly combined with oral daily ribavirin is the most effective therapy. There is no vaccine available for hepatitis C. Complications are chronic hepatitis and acute liver failure is low. For hepatitis D, it's the smallest known animal virus, and, and it can't produce infection without concurrent hepatitis B infection. Diagnosis is IgM antibody to hepatitis D virus, and treatment is supportive. There is no vaccine to prevent hepatitis D infection. Hepatitis E, formerly called non-A or non-B hepatitis, is also transmitted to like hepatitis A, wherein there's fecal oral route transmission. It is similar to HAV in symptoms but is often more severe. Diagnosis is made by requesting anti-HEV IgM and IgG. Here is the summary of diagnostic blood tests to be done for the different viral hepatitis. Kindly read this slide. The next disease to be tackled is biliary atresia. It is progressive obliterative cholangiopathy. Biliary atresia has three main types. Atresia of the common bile duct, which accounts to 10%. Atresia of hepatic duct, accounting to 2%. And the most common is the atresia of the at the porta hepatis, accounting to 88%. Biliary atresia. Most children with biliary atresia are normal at birth and have a progressive obliteration of the bile ducts. The embryonic or fetal onset form manifests at birth and is associated with other congenital anomalies like situs inversus, polysplenia, intestinal malrotation, complex congenital heart diseases, with an incidence rate of 1 every 10,000 to 50,000 births. Here is a photo of a child with biliary atresia. Noted the distended abdomen with jaundice and engorged veins on the abdomen. To differentiate biliary atresia from idiopathic neonatal hepatitis, familial incidence is unlikely in biliary atresia, but there is a colic stools for biliary atresia and the liver is enlarged for biliary atresia. There is no single diagnostic modality best for diagnosing bronchial. There is no single diagnostic modality best for diagnosing biliary atresia. Diagnostic schemas incorporate clinical, historical, biochemical, and radiologic features. For ultrasound, there can be abdominal polysplenia and vascular malformations. Gallbladder is not visualized or there is a microbladder, and there is the triangular cord sign. It represents a cone-shaped fibrotic mass cranial to the bifurcation of the portal veins. Hepatobiliary scintigraphy, wherein the hepatic uptake is normal, but excretion into the intestine is absent for biliary atresia. Percutaneous liver biopsy will reveal bile ductular proliferation, bile plugs, portal and perilobular edema and fibrosis, with the basic hepatic lobular architecture intact for biliary atresia. Exploratory laparotomy and direct cholangiography can be done to these patients. Hepatoportoenteroscopy or Kasai procedure can also be done, but the definitive management is still to do liver transplant. Kasai procedure should be performed before 8 weeks of life. Now we go to intestinal parasitism. Ascariasis is most common in the tropics and is caused by Ascaris lumbricoides. It is the most prevalent intestinal parasitism and looks like a plate of spaghetti. The Ascaris ova hatch in the small intestine after ingestion by the human host. Larvae are released and penetrate in the small intestine and migrate to the lungs by venous circulation. The parasite causes pulmonary ascariasis as they enter the alveoli and migrate to the bronchi and trachea. They are subsequently swallowed and return to the intestines, where they mature into adult forms or worms. The female ascaris begin depositing eggs in 8 to 10 weeks. Clinical manifestations are vomiting, abdominal distension, passing out of worms in vomitus and in stool. Diagnosis is made by microscopic exam of fecal smear. Clinical manifestation should also be considered. Prevention is universal treatment of children in the primary school. Hookworms, on the other hand, is caused by Necator americanus and Ancylostoma species. It is most prevalent in areas where human feces are used as fertilizers and if there is inadequate sanitation. These are the microscopic photos of hookworms. For the pathophysiology, the larvae penetrates to the skin, where they migrate into blood and goes to the lungs, then eventually swallowed and eventually grow to adult worms. They adhere to the intestinal mucosa and submucosa of the proximal intestines by using their cutting plates or teeth and a muscular esophagus. Rupture of the capillaries followed by extravasation of blood, leading to anemia, and further anemia, with a zero point 0.2 ml of blood loss per day. There can be iron deficiency anemia for hookworm infection. There's physical growth retardation as well. Diagnosis is made by clinical symptoms, and there can be microscopic exams on fecal smears showing the eggs. Treatment is albendazole, mebendazole, and pyrantel palmate as an alternative. Prevention is still best by giving periodic deworming. Trichoriasis, or is caused by Trichoris trichiura and is usually seen in rural areas with inadequate sanitary facilities. The soil is contaminated with human or animal feces. For the pathophysiology of trichoriasis, there is ingestion of the barrel-shaped eggs. The larvae then escapes from the shell in the upper intestinal wall and penetrates the intestinal villi. The worms slowly move towards the cecum. Clinical manifestation is chronic dysentery and rectal prolapse. These are the photos of rectal prolapse. The one in the bottom is the most severe form of rectal prolapse. Diagnosis is made by viewing or identifying barrel-shaped ova in the feces. Treatment is mebendazole and alternative is albendazole. You can also give nizatoxanide. Improved sanitation is the best way to prevent trichuriasis. Enterobiasis is caused by Enterobius vermicularis and usually present in areas where children live, play, and sleep closely together. It is transmitted by the fecal oral route, and autoinoculation is possible by putting fingers in mouth after scratching the anus. Enterobiasis presents with perianal pruritus because the gravid female migrate at night to this area where they deposit 15,000 eggs per night, and then there will be restless sleep for children. Diagnosis is made by placing an adhesive cellophane tape early in the morning to detect eggs or worms. This is a photo of enterobiasis. Note that adult worms are attached in the anal area. Treatment is by giving mebendazole and albendazole, as well as pyrantel palmate. And there should be frequent changing of underwear and beddings of these children. Prevention is still improved sanitation. In summary, Hirschsprung disease presents as failure to pass out stool, Meckel's diverticulum as painless rectal bleeding, biliary atresia as colic stools, acute gastroenteritis presents with diarrhea, viral hepatitis presents with jaundice, and intestinal parasitism as passage of worms. The reference for this session. Here are the references for this session. Here are the references. Thank you, and please answer the post test.